preoperative imaging in mesenteric ischemia, or maybe we should say pre-interventional imaging in mesenteric ischemia. I have no conflicts. So the diagnostic evaluation of both acute and chronic mesenteric ischemia center around the same signs, just a different presentation. Our colleague nicely explained how to approach the cases clinically. So we end up with imaging requirements to confirm the diagnosis. And as already was said, CTA is the preferred diagnostic modality, and both in acute and in chronic. You can use duplex ultrasound for the screening, and sometimes it's also readily available in the emergency department, so it can be used as a first-line assessment. For the stenosis evaluation, the arterial phase is the most important. The portal venous phase can assist for the venous and abdominal evaluation in addition to the vasculature. Non-contrast is optional to establish the diagnosis, and a neutral oral contrast for bowel distension can be considered, even though I think in the acute phase it's not very feasible. So what signs are we looking for then on the CT? Well, there can be, of course, portovenous gas, bowel distension, intramural gas, and we can have attenuation abnormalities in the bowel. So we see a normal attenuation of the bowel wall here on the left side of the abdomen, and in the lower abdomen there's a clear lack of contrast enhancement and slight thickening of the wall. Mesenteric fluid and atherosclerotic calcifications are also very common. If we then go to the contrast phase of the examination, specifically we can evaluate the stenosis, which is sometimes very proximal and easy to diagnose, and sometimes more distal and more complex in nature and more in its location. You of course also can have arterial but also venous thrombosis that can be diagnosed on the portal venous phase images best. So what are the criteria then? A significant stenosis is 70% stenosis of either the celiac artery or the superior mesenteric artery. Both or a single vessel disease are enough for the indication to consider treatment in clinically symptomatic patients. And it applies both in acute and chronic cases of mesenteric ischemia. Important evaluation in these patients can also be what are you going to do with the approach. It's going to be a brachial or a femoral approach. You can consider extending your CT imaging to the thorax to know if you have a safe access if you want to go to the brachial approach. And it's interesting to see that in our recent years, when we used to do quite a few cases through the brachial approach, the exposure to radiation was actually quite high. The average, as you can see here in the examples, averaged around a millisievert for each case with 1 or 2 vessel access. And we were able to reduce that tremendously by switching to preferably the femoral approach with steerable sheets, which are the tool in our arsenal that makes a very big difference, and also is much more safe for patients and the physicians treating these patients. So, in conclusion, the ideal imaging approach for acute mesenteric ischemia for interventionalists is abdominal CT with IV contrast, and you should consider also imaging your access points. What can imaging confirm? Well, the clinical diagnosis, the extent of the disease to treat, the required materials, your approach, and if you want, you can already prepare your balloon and stent sizing prior to performing your angiography. Thank you for your attention.